everyone, my name is Hannah Mata and I am the board-certified music therapist for Houston Methodist Willowbrook Hospital. While music therapy may not be new to Houston Methodist, it is new to Willowbrook and the NICU. This presentation will provide you information about music therapy and about the services that will be implemented in the NICU. Let's get started. The objectives for this presentation will be to define music therapy and neonatal intensive care music therapy. We'll be discussing music versus environmental sounds. I'll be describing some music therapy interventions for the NICU here at Willowbrook and supporting research. I will discuss referral criteria along the way. I will also go over some collaboration methods, safety measures, and discuss how to request music therapy. So what is music therapy? According to the American Music Therapy Association, it is officially defined as the clinical and evidence-based use of music interventions to accomplish individualized goals within a therapeutic relationship by a credentialed professional who has completed an approved music therapy program. Now, there are some common misconceptions about music therapy, so I'm going to review a couple differences between what music therapy is and what it is not. Music therapy is an allied health profession. We conduct assessments, create goals and objectives, and measure clinical outcomes. It is heavily research-based. However, music therapy is not without a therapeutic relationship or a certified therapist. It is not provided by volunteers, so clinical training is necessary, and it's not entertainment. Houston Methodist does hire musical entertainers through the Center for Performing Arts Medicine, otherwise known as CPAM, which you often see in the lobbies of Houston Methodist hospitals. This is a wonderful, amazing service, but they do not provide treatment interventions for patients or track their progress. What is neonatal intensive care music therapy? The National Institute for Infant and Child Medical Music Therapy states that NICU music therapy is the provision of evidence-based music interventions by a credentialed music therapist in the NICU to address neurodevelopmental and psychosocial clinical goals for premature and full-term infants admitted to the NICU. There is well over 30 years of clinical research supporting the training and safety of music therapy in the NICU. Much of this research shows that NICU music therapy improves patient outcomes, shortens NICU stay for premature infants, and reduces medical costs overall. NICU music therapists requires postgraduate training, research, and clinical fieldwork. Music therapists that are trained in the NICU practices use specific techniques to protect the infant from overstimulation and ensure the best possible care. NICU music therapy for Willowbrook will be comprehensive. Now, what I mean by that is there are two different approaches to practicing music therapy in the NICU. The first is known as First Sounds, Rhythm, Breath, and Lullaby, established by Joanne Lowy, and this approach is in association with Mount Sinai Hospital in New York. The other approach is known as NICU music therapy, established by Dr. Jane Stanley. Her approach is in association with Tallahassee Memorial Healthcare and Florida State University. The first approach is based on psychosocial principles and biological rhythms, while the second approach leans more towards neurology. Oftentimes, NICUs have music therapists trained in only one type of approach. Here at Willowbrook, we will be leading the way in medicine by implementing both schools of thought. This will address the diverse needs and the size of Houston Methodist Willowbrook's neonatal intensive care unit. Now let's talk about music versus environmental sounds in the NICU. There is a vast difference between how neonates receive music as opposed to noise. So the human brain can process organized sound or music much more easily than random environmental sound. And individualized music can mask harsh environmental sounds. Research has shown that music therapy has significantly better outcomes compared to environmental sounds for premature infants' respiration and oxygen saturation. A study by Collins and Cook in 1991 observed 17 agitated premature infants under music and silent conditions. Oxygen saturation levels were significantly increased by just one 10-minute trial of auditory stimulation as opposed to silence. Another study by Cassidy and Stanley in 1995 observed physiological responses to severely premature infants under music listening conditions as compared to normal environmental sounds. Music immediately and positively affected oxygen saturation levels, heart rate, and respiration rate on day 1. Now let's go over the evidence-based music therapy interventions that we will be implementing at the Neonatal Intensive Care Unit here at Willowbrook and some supporting research. Now, all music therapy interventions are research-based, but I'm only going to talk about a couple studies. If you would like some more information about research, just reach out to me and I'll be happy to get you that information. The first intervention that will be added to the NICU is known as systematic neurodevelopmental stimulation with music. This is a common NICU music therapy intervention. The idea is that premature infants have very low tolerance to sensory input, as you well know. They are receiving stimulation that they otherwise would not be experiencing in the womb. So this intervention is designed to help infants habituate and get used to these sensations, so they don't have as many startle responses or agitated episodes as a result of touch that is necessary for the infant's medical care. The protocol involves the music therapist implementing a systematic use of gentle auditory input, cephalocalatal proximal distal touch, and then gradual vestibular input as the infant tolerates. So it begins with a soft humming, then singing a lullaby, then adding neurodevelopmentally appropriate massage, and eventual rocking. Infants are carefully and continuously observed for signs of disengagement, and the protocol is either paused or stopped immediately when any signs or symptoms appear. It was originally derived from the HMWB stimulation program, and research has shown that this systematic progression fosters neural activation and maturation of the regulation system. When infants spend more time in homeostasis and respond positively to stimulation, their development occurs at a faster rate than infants still reacting negatively to stimulating procedures. A second important part of this protocol involves myself teaching and educating NICU parents on how to use this protocol themselves and how to observe their child for signs of overstimulation. So I teach the parents how to look for those stress cues, how to use their voice in a calming manner, and this is an effective way to nurture their infant and increase bonding. Research has shown that this training helps parent avoid overstimulation, and it has been shown to increase parental visits as well. The referral criteria for this intervention are for infants who have achieved at least 30 to 32 weeks gestational age, are considered ready for minimal levels of stimulation, or infants who have been observed to be hyper-responsive to touch and are easily overstimulated. It's also great for parents who are wary of interaction with their child, or parents who have been observed to overstimulate their child. This is a 2012 RCT study on neurodevelopmental stimulation. It involved 108 infants from 4 different NICUs in Florida and Texas, and they were randomly assigned to 3 different groups. 2 of them were experimental groups. One of them combined neurodevelopmental stimulation plus voice, and the other combined the protocol plus voice and guitar. The control condition, which was the third group, had no music therapy at all. The infants were less than 37 weeks gestational age, and music therapy sessions lasted about 20 minutes and were provided at least once a week by a music therapist for the duration of their NICU stay. The results showed that experimental babies went home on an average of 12.9 days sooner than control babies. There are also some interesting gender differences that were discovered in this study. The experimental males went home 8 days sooner, and the experimental females were discharged 15.7 days sooner. Experimental males also responded better to voice-only interventions as opposed to voice and guitar. And prior research has shown that premature males have demonstrated lower sensitivity to high frequencies in hearing screenings than premature females. So these differences support the adherence to separate intervention protocols for males and female infants receiving music therapy. And I've already implemented this in our NICU. Some of you have already seen me use guitar with females but not with males, and this is why. This study also found that experimental infants had a lower average number of days to full feeds compared to control infants. The infants receiving music therapy also had a lower number of days on IV nutrition compared to infants that did not have neurodevelopmental stimulation. The theoretical concept supporting the use of this protocol postulates that infants interpret and respond appropriately to the music and other layered stimuli, and there is a positive emotional activation and a decrease in negative emotion activation that occurs in the brain. This allows for greater integration of stimuli to advance self-regulation skills. Stimulating activities such as transferring out of the isolette, being held, being fed, being touched, moving through space, and eye contact are tolerated by the infant with increasing frequency as neurodevelopmental stimulation interventions progress. Music therapy can also be used for pain management. Using live music during painful procedures is an area I would like to focus on at Willowbrook. The first method is live lullabies and toning. This is when I provide a means to contain the sound environment for the infant in distress. The lullabies help pacify and soothe negative behavioral responses during painful procedures. The second method is known as contingent singing. It is defined as the use of singing to respond to the immediate interpersonal needs of the infant. The process involves me matching the physiological and behavioral sounds of the infant during the moment of distress. As the infant begins to respond to and entrain to my voice, I gradually move to a calming lullaby. The lullaby continues for the remainder of the painful procedure and afterwards in order to maintain that quiet alert state. Referral criteria may include infants who are at least 32 weeks gestational age unless approved by the attending physician. And the referral reasons could be high irritability, inconsolable crying, a request to decrease stress responses during painful procedures, pain management, or neonatal abstinence syndrome. Music therapy can also be used for feeding and non-nutritive sucking. The newborn's ability to suck is critical for neurological development. This is one of the first rhythmic behaviors an infant engages in, and it contributes to the neurologic development by facilitating internally regulated rhythms. While non-nutritive sucking is a reflex that appears with physiologic maturation, its effectiveness can be altered by learning experiences. So, in a session focused on improving feeding mechanisms with music therapy, I use an intervention with a gato box, and it's a small wooden instrument that mimics the sound of a heartbeat, and it is used to provide an external rhythmic cue for the infant to entrain to. This can regulate feeding rhythms as well as promote a continuous quiet alert state when feeding. The developing neonate first hears the mother's heartbeat as early as 16 weeks, so contributing these instrumental sounds during entrainment secures conditions that enhance growth. This intervention can be used during a co-treatment with speech therapy, nursing, occupational therapy, or one-on-one with caregivers. The referral recommendations for this intervention are the infant needs to be at least 32 weeks gestational age unless approved by an attending physician, and referral reasons can be poor and arrhythmic feeding, short bursts during feeding, poor non-nutritive sucking, poor weight gain, or respiratory difficulties. Music therapy can also be used for bonding, and it's through an intervention known as Song of Kin. And this is when a melody is identified by a parent that has been used within a family's history or at the present time that is representative of the family's culture. After the parents identify a culturally relevant song, I recompose that song to a lullaby and teach it to the parents. During the assessment process, I learned the timbre and melodic range of the mother's speaking and singing voice so that I can sing the Song of Kin in the most effective way possible when the caregivers are not present. Music can intricately affect the growing infant's care because the culture and musical preferences are audible to the infant in the womb. So it ultimately fosters a sense of containment and resiliency as it represents what is safe and familiar. This intervention also involves me providing music psychotherapy sessions for the parents. This is a powerful means of non-confrontational support for the caregivers and is a parallel process that provides useful skills in transferring these gentle interventions to their baby. This parental education results in continuity of care that they can use after they've been discharged. This was a study done in 2015 on the differences between parent-selected Song of Kin versus a pre-composed lullaby or Twinkle Twinkle. There were 272 premature infants in the study from 11 neonatal intensive care units. The results were collected on vital signs, feeding behaviors, activity level, sepsis, and sleep patterns. Data ratings on parental stress pre and post music therapy were also collected. And then there were 4 days with no interventions or no music therapy that served as a secondary control measure. The live singing of Song of Kin was entrained to match the breathing sounds of the infant's inhalation and exhalation meter and was provided in the morning and evening, and vital signs were collected by a healthcare professional before, during, and after interventions were implemented. The same vital signs were also collected when no music therapy was provided. The mean number of each of these readings were calculated for each phase of analysis. Here are the results for the study. If you notice, Song of Kin had a significant effect on feeding behaviors. There was an increase in sucking rate and in total caloric intake when Song of Kin was used, and there was also a decrease in sepsis. This outcome implies that feeding incurs the most incentive for infants when parents are utilizing melodies that are original and unique to their culture and preferences. Now, Twinkle Twinkle had a better outcome for respiratory behaviors and oxygen saturation. And this is because if you think about the melody of Twinkle Twinkle, it slowly ascends and then descends. And it's easy for the infant to entrain their breathing to the melody line. And this is why you see a decrease in respiratory distress. Parental stress was also reduced with music therapy. Results were also gathered on lullaby versus no music therapy intervention. And the findings showed that music therapy had a significant benefit during painful or regulatory procedures. So a calm, alert state was increased when a lullaby was used during those procedures as opposed to not. Heart rate was also decreased during procedures as compared to the control group. And sleeping also increased with the lullaby. So this just confirms and supports the use of music therapy interventions to support the everyday necessary medical procedures in order to improve infant medical outcomes.
Music therapy in general is using music to address everyday goals and objectives. Here specifically, we like to work on pain management, feeding facilitation and feeding behavior, as well as heart rate and oxygen saturation. We created what we call a Song of Kin, and they start to sing that to their baby when things are nice and calm. Basically, if the baby's really fussy, so today he was really fussy because he wanted his milk. And so we started singing the Song of Kin to try and get him to remember, oh right, this is the time when I calm down. As I'm doing all of that, I'm constantly looking for signs of overstimulation, because we do not want the baby to be overstimulated. Then everything we've done basically goes out the window. We did some feeding facilitation with Miles, and I used the Gato box, which is a major third, and it simulates the heartbeat. It's also really great for sucking behavior. And so what I do is I pace with him when he's sucking. I start out, each suck, I tap the Gato box, and I entrain with him. And then as he's going, he starts to entrain with me so that I can get him to pace and suck, swallow, breathe. Yeah, he's very comfy. Hello. Hi, buddy. The opening is on. Baby Silas, he has just started to be able to get music therapy. I've been going in and just singing for about 10 minutes at a time with him. He's so young that right now guitar would probably be too overstimulating. But as he gets older, I can keep doing music therapy and do it for longer periods of time. And it's also great for language development as well as neurodevelopment. So if we can just get a really nice, calm, relaxing environment, it helps everybody.
Now let's talk about collaboration with the Houston Methodist Willowbrook team. This is an amazing way to provide the best possible care for infants and their families. While I can do certain interventions independently, such as neurodevelopmental stimulation, I will always reach out to the attending nurse to receive approval for treatment. Nurses are experts on the day-to-day care of the infant, so your knowledge and approval are incredibly important for me to implement music therapy safely. I would love to do co-treatments with nursing and provide procedural support, such as using music therapy for pain management, helping the infant regulate to their environment, and assisting in maintaining a quiet alert state during necessary nursing interventions. Next, music therapy can be used to co-treat with rehabilitation specialists. When we co-treat and collaborate, we will be addressing the same goals and objectives during the session. Music therapy can be added during feeding interventions, aiding in developmental milestones, and applied to physical therapy treatment sessions to decrease infant pain responses. Let's talk about safety measures. Since the safety of neonates is so important, there are ways to safeguard the best possible care for infants during music therapy sessions. First, I will ensure that the decibel level of any cumulative music does not exceed 65 to 70 decibels, and this is in accordance with the American Academy of Pediatrics Committee on Environmental Health. Any music is ceased when symptoms of disengagement occur, and this significantly reduces any risk of discomfort. The decibel level will be monitored with a digital sound meter. The top of the sound meter is foam and can be removed and interchanged. So the top will be changed with a clown nose for each infant in order to follow infection control policies. So passive music listening is another great way to provide music for the infants outside of music therapy sessions. To have the best possible outcomes, findings in a 2014 study recommend that recorded music should not exceed 4 hours daily. And if possible, go ahead and ask Alexa to play lullabies in order to avoid overstimulation. How to request music therapy. Referrals for music therapy can now be assigned through Epic. To do this, search the word music under the Orders tab. Make sure the music therapy consult is highlighted and hit accept. If the reason for referral is not listed, please let me know in the comments section. You may also call Hannah Manon-Vacera to reach me. And my work hours are listed here. I am currently part-time at 20 hours a week. And lastly, feel free to email me if you have any questions or if you would like to schedule a co-treatment. This concludes the presentation. I am incredibly grateful to be joining the amazing Houston Methodist Willowbrook team, and I'm so excited to be adding music therapy to the NICU. Thank you for watching.